Hello and welcome to this CME symposium titled Interleukin-33 and Lower Tract Respiratory Diseases, Moving from Pathophysiology to Management. We're pleased to have participants from across the country here today, not only in this room, but also viewing online. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. Everyone in the live audience should have the following items at their place setting. A keypad to respond to polling questions. Your responses are anonymous and very important to the educational outcomes of this program. A workbook and postcard with program information, presentation slides, and a link to valuable clinical resources. An evaluation form. Please complete both sides before you leave to receive CME credit and help us improve future activities. For those joining us online, the system will prompt you to answer polling questions, and all program information is available under the Handouts tab on the right side of your screen. The evaluation will automatically open in your web browser following the conclusion of the program. During the presentation, if you have a question, please write it on the questions card in front of you, and ushers will be around to collect them. Online participants can submit questions via the Q&A box on the right side of the screen. Now, let's give a warm welcome to our presenters. Dr. Jonathan Hand, Professor Dave Singh, and Professor Tom Wilkinson. Enjoy the program.
Well, hello, good evening, and a warm welcome to a rare event, a Sunday evening symposium. So thank you all for spending some of your time with you. With my esteemed colleagues here, we're going to spend about an hour and a half talking about a really exciting emerging area of biology and therapeutics in Interleukin-33 and to consider how this may be a platform for new treatment strategies in respiratory disease. Here are our disclosures from myself and my two colleagues. So there are some educational objectives this evening, and really that's to update our understanding on IL-33 biology. It's a fascinating molecule that has a number of actions, and we're going to review what those are. To think about its role in disease, and to look at the emerging trials data that could inform our understanding about how we may use new strategies to treat respiratory conditions, both chronic and in terms of acute infection. So, as you've heard, we're going to ask you to participate this evening, and on your tables you have a little keypad there. And so first of all, we're going to find a little bit about you as practitioners. So we're just interested to see who's in the room, and so if you could answer this question for us. Okay, so a mixed group from people not managing COPD, some busier clinicians here, and some people from industry and others, I suspect. So thanks for that. So another similar question about yourselves before we dive in. So the other indication for this approach is in respiratory infection. Jonathan will be handling that side of the presentation. We're interested to see how many of you are treating those sort of patients. So same again, if you could press the button. Okay, so quite a lot of you managing respiratory infection. It's one of our commonest presentations that we manage as pulmonologists in the UK. And this is a fascinating area, emerging host-directed therapeutics for an indication that's so common. Right, now we're going to ask you how you feel about this area. So the idea here is that we ask you one or two questions around the role of IL-33 and treatment trials, and then we'll ask you some similar questions at the end. And hopefully, we've seen that we've added to your knowledge base by discussing this area. So pre-test question 3, serum stimulation to ST2 independent IL-33 pathway has been shown to. Please select one of those answers which you feel is the appropriate one. Okay, thanks for that. That's quite a tough one. And then we're going to show you the answers at the end. And then this is the final one of this bout. In the phase 2 placebo-controlled studies in COPD, the two drugs targeting IL-33 were both found to have what common result? So again, if you could select one of those 4 answers for us, please. Okay, thanks for that. Okay, so we're now going to spend the first part of this evening looking into this emerging area of understanding, the biology of interleukin-33, its origins, its role as a complex pleiotropic molecule that has a number of effects in different settings, and its role in disease. And we've created a video really just to give you a snapshot of some of the key areas of the biology, which we'll play first, and then I'll just talk through some of the key points from that. So on to the video.
The structure of the lungs allow efficient oxygen exchange while providing a barrier against inhaled particulate matter. Additionally, they are a crucial organ in the immune system, providing the first line of defense against inhaled microbes. Cytokine signaling in the airways coordinates the innate and adaptive immune responses, mediating inflammation, tissue repair, and other host defense responses to pathogens and allergens in the lungs. Dysregulation of these processes can result in inadequate host defense and excessive immune responses, resulting in system inflammation. Now, this can cause changes to the airway epithelial structure and function, resulting in irreversible remodeling of the airways. Interleukin-33, or IL-33, is a member of the interleukin-1 cytokine superfamily that is constitutively expressed in the nucleus of many cell types, particularly epithelial and endothelial cells. Under healthy conditions, IL-33 is a dual-functioning cytokine, acting as a nuclear transcription factor and a pro-inflammatory alarmin. The other alarmins are interleukin-25 and thymic stromal lymphopoietin, or TSLP. After exposure to allergens, pathogens, cellular stress, or tissue damage, the full-length precursor, IL-33, is quickly released and alarms the immune system, signaling through membrane-bound receptors called serum stimulation 2, or ST2. These receptors are expressed on the surface of a wide variety of immune cells, including resident eosinophils, macrophages, type 2 helper T cells, and type 2 innate lymphoid cells. During this process, full-length IL-33 is cleaved into shorter bioactive forms by inflammatory proteases secreted by mast cells and neutrophils. The IL-33 membrane-bound ST2 complex associates with ubiquitously expressed IL-1 receptor accessory protein to trigger type 2 signal by activating the transcription factor nuclear factor kappa B, NF-kappa B. This leads to the expression of the pro-inflammatory type 2 cytokines interleukin-4, interleukin-5, and interleukin-30, with the promotion of downstream inflammatory responses. Additionally, IL-33 ST2 signaling activates a range of non-T2 inflammatory responses that lead to increased neutrophil migration and activation, and the expression of the cytokines interferon gamma, TNF-alpha, and interleukin-6, which further promote downstream positive feedback loops amplifying inflammation. The activity of IL-33 is tightly regulated by the release of a soluble version of ST2 by mast cells and T cells. This serves as a decoy receptor and dampens the downstream inflammatory effects of interleukin-33. Oxidation of IL-33 causes a conformational change that prevents IL-33 from binding to the ST2 surface receptor. However, oxidized IL-33 can bind receptors on the surface of epithelial cells, called receptor for advanced glycation end products / epidermal growth factor receptor, or RAGE/EGFR receptor. This activates an ST2 independent pathway that modulates the function of the airway epithelium, including impaired epithelial wound healing and mucus liposecretion. In certain pathological states, such as COPD or severe viral lower respiratory tract infection, ongoing IL-33 signaling appears to contribute to disease development and progression. The potential multifunctional roles of IL-33 in these disorders have made it an attractive therapeutic target in airway diseases, with ongoing research investigating the effects of blocking IL-33 signaling pathways.
Thank you, and thanks to Dave for his very elegant voiceover of that complex cartoon. So that's covered really everything I need to do, but what I'd like to do is just pull up some of the key messages from that presentation which can inform us in our thinking about IL-33. So there's a complex biology there, and when we're thinking therapeutically, the more we understand about that, the better decisions we'll eventually be able to make for our patients, and our understanding of trials and differential results will flow as well. So as we heard, IL-33 is a protein with a number of functions. It's part of the IL-1 family and sits right at the top of a cascade of responses to stimulation such as infection, toxin inhalation, and other challenges such as allergens. It has several domains, three main domains, of which the two ends are important. So on the N-terminal, there's a role here in transcription control. So it sits in the nucleus, controls the transcription of key proteins that could be involved in cellular responses. And at the other end, it has a key role as a cytokine, an inflammatory, pro-inflammatory cytokine. And it's termed an alarmin because it really sits at that first stage. If you think of it as an alarm to challenge, then that's a good way of imagining its role in that context. We also heard that it's held in the nucleus, so it's actually constitutively expressed in many cell types, including epithelial cells, including endothelial cells, and the importance of infectious disease will emerge there, but also in fibroblasts and other structural cells in the lung. And it can be released by a number of ways. So either passively released by necrosis during necrosis, or actively secreted following this stress response. And here on this slide, you can see that it can be released, therefore, in response as an alarmin to various different triggers. And we'll explore those now. As we also heard on the video, that the signaling pathways are more complicated because it can sit in two forms. It's constitutively released in its reduced form, which binds to the ST2 receptor, which is expressed on a number of cell types, particularly inflammatory cells, and signals down through the IL-1 ST2 signaling pathway. But actually, in the complexity of lung disease, it is often oxidized and therefore can no longer bind to the ST2 receptor and actually stimulates the RAGE-EGFR pathway. And that pathway is much more involved in remodeling, in epithelial changes, and more chronic changes to the milieu. So if we look at the ST2 pathway in a little bit more detail, I think the video captured this well. The ST2 receptor is expressed on a whole array of inflammatory cells, and both innate cells, as shown here, mast cells, basophils, eosinophils, and innate leukocytes, but also adaptive cells, particularly T helper cells. And so one can imagine that it's playing a really key role in orchestrating an inflammatory response, which may be quite different for different patients depending on other factors. And as we know, it's sitting right near the top of this cascade, so it has an important role in stimulating not only Th2 inflammation, but other forms of inflammation, which may be important in conditions such as COPD. If we think about the other pathway, the RAGE-EGFR pathway, as we've said, this is an oxidized signaling pathway and has an effect on the actually constitutive appearance and performance of the epithelium as a barrier. So increased stimulation of RAGE-EGFR leads to things like mucus hypersecretion. It can diminish epithelial defense and barrier function, and actually can impair wound healing and indeed epithelial healing in the chronic state. So again, in conditions of chronic inflammation such as asthma and COPD, this may be an important axis that could be modulated. And finally, we thought about the regulation. This is a really potent biological molecule, and clearly evolution has led to a number of key ways in which this molecule is naturally regulated in the lung and in any other organ. We know that it is sequestered and held in the nuclei, and that has a direct effect on cellular transcription, but also allows the rapid release of this molecule when stress factors occur. We know that this can be inactivated by proteases, including caspases, and other proteases, including neutrophil elastase and cathepsin. And so the inflammatory milieu of neutrophil inflammation, for example, can alter its biology. Thirdly, it can be inactivated by oxidation, as we know, and that prevents it from binding ST2. And lastly, there's soluble ST2 receptors widely circulating in all biological fluids, and that can sequester this molecule and stop it signaling through cellular pathways. So it's a very complex milieu that we're trying to understand. So what I'd like to do now is just think about this biology in the context of inflammatory lung disease, and we're going to focus on asthma and COPD. Then I'm going to hand over to Jonathan, who's going to think about this biology in the context of viral infection. So before we do that, we're just going to ask you another question. So if you could grab your keypads again. And this is to ask you really about how you feel about this biology in the context of those indications. So how confident are you currently, as of this minute, in your understanding of this signaling pathway in lower respiratory tract disease and infection? So if you can answer that one for us. Okay, so we've got a mixed response there. No one is extremely confident, so that's we'll see if anyone's willing to change their opinion at the end. I won't be asking questions, so don't worry. Some people are not confident at all, and some have some confidence. So there's room for growth here. Okay, so what about the role of IL-33 in asthma? And actually, this is a fascinating area, and I think there's a lot of research still to be done here. But the earliest associations between the role of this alarmin and asthma came from genome-wide association studies, GWAS studies, which linked the abnormalities, SNPs in the IL-33 gene with the risk of developing asthma. And there has been a number of studies, and in fact those have all shown similar results, and there's increasing confidence that these are real and important findings. So the IL-33 ST2 axis is implicated in asthma susceptibility, but quite how and why that is, I think the jury's still out, so more work is needed there. But we know there's a statistical relationship between the presence of these abnormal signaling genes and the presence or prevalence of asthma. So let's think why that may be. Well, we know this is a complex milieu, and we're going to show you a few slides that look a little bit like this in the different indications. But to focus on the key messages here from a complex picture, one is that this is very high up in the signaling cascade, so it's coming largely from the epithelium, but potentially also from endothelial sources. And it can signal through a range of inflammatory cells, which are important in different endotypes of disease. And in asthma, clearly the Th2, the T2 signaling pathway is really important. And you can see here that it could influence the secretion and expression of important cytokines such as IL-4 and IL-13 through this cascade. But even in asthma, non-T2 disease is really important. There are less therapeutic options in that pathway at the moment, and so like TSLP, IL-33 is a tantalizing potential target in patients that are not necessarily going to respond to T2 modulation alone. And so that's a key message we'll carry forward into our other disease areas. So what about in COPD? There's probably less data available in terms of COPD. The genetics of the condition are less well understood, firstly. But if we look at the relationship between IL-33 gene variants and COPD incidence, again we see an interesting emerging story. So there are natural experiments, there are loss and gain of function polymorphisms of the IL-33 gene. So if we can identify the relative risk of COPD in patients carrying those types of genetic variants, then that may tell us something about the biology of this pathway. So in a loss of function variant was associated with a 21% reduced risk of developing COPD, indicating that IL-33 may be important in the disease. And a gain of function of that same gene were associated with increased odds. So this naturally occurring cytokine seems to be associated with the presence of COPD as a risk of developing the condition. And again, if we look at the complex milieu of inflammation in COPD, we can draw out some other strands of interest. So yes, T2 signaling is important in that condition, but the majority of patients don't have T2-mediated disease, and other cascades of inflammation are also important. And here on this slide, you can look at the neutrophilic inflammation, the role of interferon signaling, and a key T cell here perhaps stimulating that is the Th17 cell, which has a key role in stimulating neutrophilic responses. But in addition, there is through the other pathway, the modulation of the epithelial layer, and the fact that metaplasia in COPD is common, and IL-33 may be a key stimulant to that signal, and that Barrett's dysfunction, goblet cell hyperplasia, mucus hypersecretion could all be affected by this access. So it's interesting to think about that when we move on to the studies and we try and think about a responder population to these molecules. So there we have it, a summary of that concept really, that T2 inflammation is present in a minority of patients with COPD. There are a number of targeting molecules against those, and the studies are emerging, but they're actually, the lion's share of inflammation in COPD may not be T2 related, and again, this is where IL-33 modulation may play a really interesting role beyond T2 inflammation to a range of stimuli. And we're going to consider moving forward how that is affected by cigarette smoke, by infection, and by other biological agents. So that's the end of my slides for the minute. And now we're just going to talk to my colleagues here about some of the interesting features and controversies about this. So I'm going to ask Professor Singh his thoughts on this question. So we know that IL-33 signaling is important in the biology of COPD, but how does it relate to the severity of disease, and what can we learn from that?
Yeah, thanks, Tom. So I think there's quite complex data around this, depending on where you measure IL-33. You can measure it systemically, you can measure it in an upper airway sample, the sputum, you can measure it by immunohistochemistry. And the results from all these different methods tend to give us slightly different patterns, which I think do tell us something. So if we start with the immunohistochemistry, so looking at airway biopsies, looking at small airways, there is good information that patients with more severe disease have higher expression of IL-33 in the epithelial layers. And what's interesting to me is that when you look closely, it's highly expressed in the basal epithelium. And then when there's areas of remodeling and repair, it's even more highly expressed. And I think that tells us something about the potential role of this cytokine, this alarmin, in the role in chronic inflammation, repair, remodeling, and ultimately the small airways with that repetitive cycle become destroyed in COPD. And interleukin-33 may well be one of the key molecules involved in those processes. So that's a chronic role, but then the term alarmin, and Tom described it earlier in the slide, which showed the various signals that can release this molecule. And remember, when there's damage to cells, interleukin-33 is released. So when there's a viral trigger, when there's other infections, there could well be a sudden spike of interleukin-33, and Jonathan's going to talk more about that later during infection. So I think we have two roles here in COPD, a promotion of chronic inflammation in the, if you like, the steady state, and then spikes where it may well play different roles. Layered on top of that, then, there are some studies showing a relationship between interleukin-33 levels in the blood, in upper airway samples, sputum, and eosinophil counts. And I think some of that might just relate to the fact that it's easier to measure type 2 inflammation in the sputum. And this doesn't mean that interleukin-33 has more of a role in type 2 inflammation than non-type 2 inflammation. It just means in some of those patients with high levels of type 2 inflammation, you are seeing high IL-33. And then what's the mechanism? Tom showed it to you earlier. There are a couple of mechanisms that run through ILC2 cells, run through T helper 2 cells in promoting the range of type 2 outcomes such as eosinophilia. I think the last comment I would make is about mucus production, and that's an area we need to understand more, the potential relationship between IL-33, and is it one of the dominant drivers of mucus hypersecretion? Tom.
Thank you. Very comprehensive answer, so thanks for that, Dave. So I'm going to hand over to Jonathan now. We're going to cover the next area, which is infection.
All right, thanks. So now these two awesome British accents followed by a Southern accent, so bear with me. All right, so for all of these community-acquired respiratory viruses, we see IL-33 increases and ultimately leading to, as my colleagues described, this pro-inflammatory environment and exacerbation of chronic respiratory diseases. But I think going through each of these viruses, what we currently know is important. So in influenza A and B, IL-33 actually results in better viral clearance, promoting tissue repair, lung integrity. And rhinovirus can allow for easier viral capture by the pulmonary vascular endothelium, stimulating the T2 inflammatory response. And RSV, inducing atopy, bronchiolitis, airway hypersensitivity. Inhuman adenovirus promoting allergic inflammation, playing another role here in T2 immunopathologic changes. Metapneumovirus promoting pro-inflammatory factors and playing a role in bronchial remodeling. And then in SARS-CoV-2, which we'll dig into, given we have the most experience and data for, IL-33 can mediate acute phase, wound repair, lung recovery, and then ultimately can play a role in a more long-term T-cell dysfunction. So, like I said, we learned a lot about SARS-CoV-2 and IL-33 during the pandemic. So, IL-33 is significantly elevated in moderate and severe disease when compared to mild disease, is associated with pulmonary multifocal consolidation and ARDS. And SARS-CoV-2 peptide induces production of IL-33 and along with other inflammatory cytokines clustered with IgG titers. And post-infection individuals produce IL-33 in response to virus-specific T-cell activation, and that's correlated with seropositivity. There has been a positive correlation between serum soluble ST2 levels and CRP, and negative correlations with CD4 and CD8 T lymphocyte counts and soluble ST2. And also higher levels of IL-33 was seen in post-COVID fibrosis patients. So in the schematic here on the right, just to give a more detailed explanation of what's happening here, SARS-CoV-2 infecting the airway epithelium, leading to IL-33 release, and then activating NF-kappa B, which ultimately can activate the transcription and upregulation of chemokines, CCL2, CXCL1, 2, 9, and 10. And that ultimately can lead to this inflammatory infiltration that we see with T cells, neutrophils, macrophages, and NK cells, which then leads to this inflammatory cytokine release. And NF-kappa B can also lead to the activation of the activation and transcription of those cytokines. Another fascinating thing we encountered was IL-33 and its role in the cytokine storm. And so cells damaged by SARS-CoV-2 ultimately triggering IL-33, really leading to that advanced lung inflammation and severe COVID-19 we saw. And many studies have highlighted increased IL-6 with COVID-19 as well. And I think more fascinating to me, from the infectious standpoint, for years we've always known that many types of infections increase this, you have a hyperimmune response and there's this immune thromboses, if you will. But we really learned a lot more about that during SARS-CoV-2. And you can see here SARS-CoV-2 impacting neutrophils, leading to platelet activation, release of coagulation factors, and then a direct endothelial damage. And then you can see that actually IL-33 here on your left, ultimately leading to platelet activation and release of tissue factor, leading to thrombosis. So I think it's incompletely understood, but the pathophysiology of COVID is related to this dysregulated immune response characterized by uncontrolled production of pro-inflammatory cytokines. And at this point, I think if we had some question cards, we can bring some of those up. But if not, we can come up with questions ourselves here.
Yeah, so if you have any questions, just hand them in. Anything you'd like to ask, we can cover those, either now or towards the end. Jonathan, I might ask you about this endothelial biology. So this was an emerging picture in COVID-19. So this is a biology perhaps we were less aware of in infectious disease, the concept of endothelial damage and microcoagulation. That seems like an interesting target, and do you think IL-33 modulation gives an opportunity to affect on that biology?
I think it's possible. If you look at other infections, they're bacterial infections, especially for like gram-negative infections, you'll have the LPS and triggering that sort of inflammatory cytokine response, and IL-33 be implicated in that as well. So as you can see, it's a absolutely multifaceted what actually does impact that thromboses, and it's very fascinating to try to think through if targeting IL-33 could impact or decrease that inflammatory response that's ultimately leading to thrombosis. But I think I would like to see that more in my field across the board, not just for viral infections, though.
Okay. So Jonathan, can I ask you, when Tom and I were presenting, and we're we were focusing mainly on the airway epithelium as a source of IL-33, but there is some data that you're showing as well that IL-33 can be released from the endothelium. Mm-hmm. So in severe viral infection, if IL-33 plays a role, do you think it's equally both as an amplifier of inflammation from the epithelium and endogenously released from the endothelium causing vascular damage, or more weighted to one mechanism rather than the other?
Oh, I mean, I think if all of the data on all of those community-acquired respiratory viruses, I really think it's not clear. I mean, ultimately, I think it's unclear. Yeah. But I think all of those studies are typically mouse models or some in vitro. But I don't have a great answer for you. I don't think the literature is really has a definitive answer for that, for sure. Yeah. Good question.
So we have a question from the audience. This is for you, Jonathan. Do we see the same cytokine response with other respiratory viruses other than COVID-19?
Yeah, not typically. Short answer, no. I think in certain times with RSV infection, I think there's some data that we can see that. And I'm mostly a transplant infectious disease physician, and I think it's interesting to see certain infections like disseminated adenoviral infections that aren't just confined to the respiratory tract cause significant inflammation, that there could be IL-33 mediation within that. But that's a good question, and I think SARS-CoV-2 did a lot of things that we didn't quite understand or expect it to do, and I think we're still learning lessons from that.
So we've got some emerging data on this particular question from the UK. There's a study we're running called Universal, which is looking at very severe viral infection across all pathogens. And actually, if you pick severe disease, so severe flu, RSV, metapneumovirus and others, we see very high IL-33 signals in all those pathogens. So perhaps it is a common mechanism, which is enticing when we think about it as a therapeutic opportunity.
So coming back to the sort of vascular thing, so when you have an influenza pandemic, the number of, in older people, the number of cardiovascular events go up. So would potentially interfering with IL-33 either through downregulation of inflammation or directly on vascular inflammation have an effect? Just food for thought.
Tantalizing question, yeah, that's right.
Yeah.
Yeah, and I think another point to bring up is that with flu A and B, I really just highlighted the positives of IL-33 and how there was a protective effect. And I think the jury is still out on influenza A because there are some in vitro studies that IL-33 blockade in that virus, flu A and B, is associated with worse outcomes. And these are in vitro mouse models. So it's hard to know in some situations, some patients, certain disease states, are we causing a more immunosuppressive effect that might impair with the handling of the virus? I think these are important questions that we can try to figure out. All right, now I'll pass it over to my colleague, Dave.
Thank you. So I have another polling question. So we're going to now think about the treatments, the biological treatments that target the cytokine or the downstream pathway. And how familiar are you with these agents? So it's the usual format. If you know everything about them, please answer question 5. If you're a novice tonight, number 1, and by the end of the evening, your score hopefully will have risen. Okay, good. So it's fairly self-explanatory. There's some degree of knowledge here. So hopefully I can try and help with that in the next few slides and give you the landscape of biological treatment. So I'm going to start with COPD and then move to asthma. And first of all, just some general statistics. And as we are at the American Thoracic Society, we've decided to show you tonight some US data for COPD, showing that the prevalence amongst adults is 6.5%, that's 14.2 million adults diagnosed with COPD. The number of visits to the emergency room, if I was in the UK, I'd say casualty, but that's nearly 800,000 visits, and this massive cost, 24 billion for COPD treatment. And many patients have these exacerbation events, sudden worsenings, that some require treatment in hospital, and they have multiple events, and these events carry a negative prognostic implication. And the increased morbidity in terms of decreased quality of life, reduced functionality, and knock-on effects. We've been talking about vascular. There's more cardiovascular events after these exacerbations. So a huge burden to the patient, their close family, and society. And it's an exciting time, though, because we've had inhaled therapies and great advances for inhaled therapies, and yet this burden exists, and now we have the potential for targeted interventions. And so I'm going to show you where all the different biologics that are either in late phase trials currently or have just finished late phase trials are. So we'll start near the epithelium with the alarmin pathways. These are essentially diagrams that you've seen earlier, but just in a different format. So the two major alarmins that appear to play a role in obstructive lung diseases are interleukin-33 and, as I mentioned earlier, TSLP. So we have one drug that is in phase 3 for COPD, targeting TSLP, and that's tezepelumab. And we have 3 drugs that target the interleukin-33 pathway. So itepekimab and tozorakimab that target the cytokine itself, and astegolimab that targets ST2, the receptor for IL-33. So there we have, if you like, upstream inhibitors of alarmin signaling. And we haven't had too much time to talk in depth about TSLP tonight, and that could form a whole extra evening of conversation. But TSLP has type 2 and some non-type 2 effects. So again, as a typical alarmin, causing a cascade of multiple downstream pro-inflammatory cytokines and cell activation. So downstream then, we have antibodies that target specifically the type 2 response. And 3 I will highlight: dupilumab, which targets the interleukin-4 receptor. And this receptor is involved in upregulating the responses to both interleukin-4 and interleukin-13. So that's dupilumab. And then we have a couple of monoclonal antibodies, mepolizumab and benralizumab, which specifically target the actions of interleukin-5. And interleukin-5 is one of the dominant cytokines for eosinophil production from the bone marrow, maturation, survival. Benralizumab targets the receptor for interleukin-5, and mepolizumab targets the cytokine itself. And both of these monoclonal antibodies then reduce the number of eosinophils in the circulation and tissue. In theory, at least, targeting upstream has the capacity to deal with a variety of responses, including those that are shown lower down, targeting specific components of type 2 biology as a general principle. So here are the studies in COPD, and I'm just going to generalize a little. We don't have time to go through all the data in fine detail, and we'll start at the top with interleukin-5 signaling. So while mepolizumab and benralizumab are licensed in asthma. The initial 4 phase 3 studies, so Metrix and Metrio for mepolizumab, and Galathea and Terranova for benralizumab, failed to show consistent data for the primary endpoints of exacerbation rate reduction. And these studies were enriched for patients with higher eosinophil counts. But there were learnings from these studies in terms of trial design and patient enrichment. And for both of the molecules, studies have been redesigned, and for benralizumab, Resolute is ongoing. And for mepolizumab, the Matinee study has been now reported with positive data. So for dupilumab, targeting IL-4 and 13, the Boreas and Notus studies done in COPD patients with a history of exacerbations and with type 2 inflammation, and that was defined by patients requiring to have higher eosinophil counts, more than 300 cells per microliter in the blood. And both the studies showed remarkably consistent data of a reduction in exacerbation rates of 31 and 34% in those studies. So positive data, and then consequently granting of licensing by the regulators, both in the US and in Europe. Then tezepelumab, positive phase 2 data from the course study, and that has promoted some more activity in this space, and there are other anti-TSLP molecules in this area, and tezepelumab has now entered phase 3, the EMBARK and JOURNEY studies. So that's an overview of the other biologics, so exciting, some positive data there. And now we're going to look in detail at the 3 molecules, atipicumab, astegolimab, and tozorakimab, which are the topic of tonight, targeting the interleukin-33 pathway. So let's start with atipicumab. And this was the first phase 2 publication out of all these 3 molecules. And we have a study published in Lancet Respiratory Medicine. In part 1 was the genetic association data that Tom showed you earlier. And in part 2, we had a study with about 330 COPD patients, all with a history of exacerbations in the last year. And most of you will be familiar that that's a thing that's common to COPD trials when you're looking for a signal on exacerbations. You enrich for people with a history in the last year, and the inclusion criteria here was 2 or more, and half randomized to active and half to placebo. In a phase 2 study, you're looking for 2 things. You're looking, firstly, does the drug work in the entire population? And secondly, are there particular responder subgroups? And these 2 will inform you how you will design phase 3. And it's a very common thing, and those of you who've been involved in early phase studies will know what I'm about to say next. It's a very common thing in these studies that don't have the statistical power of a phase 3 study, that you may miss your primary endpoint, but discover in your secondary analyses the responder population. And that's what seems to have happened here. So the primary endpoint in this study with 340 patients, the annualized exacerbation rate, placebo 1.6, atipicumab 1.3, so the rate ratio was 0.81. So the p-value, not significant, but maybe there's a signal for effect. And when you refine the population by just looking at the former smokers, that effect went up to 42%. So consequently, the phase 3 program has learned from this, and we have the ARIFI 1 and 2 studies specifically designed to understand atipicumab, and there's dose ranging here to understand the optimum dose, so twice a week, once every 2 weeks or once every 4 weeks. And then there's also, in the ARIFI-2 study, an arm with current smokers to confirm or refute those findings in the phase 2, that itepekimab appeared to have no effect. I didn't say that explicitly, but those were the findings. It appeared to have no effect in the current smokers. And these are studies at least a year long, very, very standard to try and understand this. And again, the patient population is enriched for exacerbation history. Now, there's no inclusion criteria based on eosinophils here. And I pointed out earlier, for the anti-type 2 treatments, the anti-IL-5, dupilumab, they're enriched for type 2 patients. But given the biology you've heard about earlier, the potential for this class of medicines to address both type 2 and non-type 2 inflammation, there's a broad range of patients enrolled. And in the phase 2 data that I showed you in the previous slide, looking at exacerbations, there was no signal across the range of blood eosinophil counts for a bigger effect of itepekimab at higher or lower eosinophil counts. Now, not to complicate the matter too much, but there was something interesting in there that at higher eosinophil counts, the effect on lung function appeared to be greater. But as I said, that wasn't true for exacerbations. And maybe we learned something there, that for some medicines, patients with type 2 inflammation, that's the mechanism by which inhibiting type 2 inflammation, you can achieve a lung function response. But reducing exacerbations needs a broader range across type 1 and type 2 responses. So now let's look at the astegolimab study. And remember, this targets the receptor ST2. So here, in a phase 2 study, and this is a single center study done in Leicester in the UK with 81 patients. And in these phase 2 studies, sometimes you don't do dose ranging. You just want to have one dose and have a look, is there enough proof here that convinces me that I will go to a large phase 3 study? So we have a 48-week study, and it's analyzed by smoking status, it's analyzed by blood eosinophil count. So a small study. Now again, the primary endpoint not met, perhaps not surprising when you have less than 100 patients. But then when you split it by eosinophil counts, perhaps there's a clue here. That the effect size, and I don't want to read too much into this, but maybe it's bigger in the patients with less eosinophils. And the 170 is the median value. So we're just splitting here the population in half. And that would, again, fit with the biology that we've reviewed, that IL-33 promotes type 1 and non-type 2 responses. So astegolimab, in the study I've just shown you, there didn't appear to be any reduced effect in current smokers. So here we have a phase 3 program of 2 identical studies, dose ranging again, conducted in both current and former smokers. And this will give the answer. There will be subgroup analyses for targeting the receptor. Will the effect be bigger in ex-smokers? Will it be equal regardless of smoking status? And again, analyzed across the range of eosinophil counts. And then we have the tozorakimab study. So I've shown you the itepekimab study with 340 patients, and then astegolimab with 81, and this one's somewhere in the middle. We have about 130 patients. And this is a 6-month study. We have the primary endpoint at week 12 based on FEV1. The patients here had a history of 1 or more exacerbations in the last year and chronic bronchitis. So some enrichment potentially for the IL-33 biology through the RAGE EGFR pathway and the upregulation of mucus hypersecretion. Exacerbations The number were too few in a population that was not enriched highly, so 2 exacerbations or more. So COPD complex was used, and this is a composite endpoint which captures both symptom worsening and exacerbation events. And in other analyses, it actually relates prospectively then to the absolute number of exacerbations. So again, the primary endpoint was not met, a 24 mils treatment effect that was not significant in favor of active. But when you refine the population for individuals with more exacerbations, 2 or more, then the effect size went up. There was no difference when you looked at it for smoking status. So this was not supportive that current smoking would reduce the effect of toziracimab. So when we look then at the phase 3 program, though, given the history of the class, the biology that we understand, it's possible that former smokers are the target population. So we have here studies done in people, COPD patients at high risk of exacerbations, 2 or more. In the Frontier 4 study that I just showed you, they seem to be the individuals with a higher effect size. So high exacerbation risk, primary analysis in former smokers, but current smokers also enrolled, again, to have a look at that. So then this raises the question, what's the reason for the potential exacerbation rate reduction with these agents being higher in people, in COPD patients who are ex-smokers? Tom, can I bring you in here? Any comment?
Yeah, so I mean, this is a fascinating observation, isn't it? That perhaps the patients where we feel that the most convincing story of inflammation perhaps is in the current smoking population, where we know there's a persistent drive to neutrophilic inflammation, chronic damage. Yet these seem to be the non-responders in at least some of these trials. So I think picking that apart is complex. We don't fully understand the biology of IL-33 in those different sectors of the COPD community. But I suppose the hypothesis generation is reasonable here. So firstly, if you have active inflammation due to cigarette smoking, there may be a number of inflammatory pathways which are activated and persistently so. So there may be a redundancy to IL-33 signaling that you don't see in ex-smokers. So that leads to a sort of workaround of the inflammatory cascade, which rather negates the effect of blocking IL-33. So I think that's a possibility. We might see a differential effect down the 2 arms of the cascade. We learned about the 2 signaling arms of IL-33, and the difference between reduced and oxidative biology is key here as well. So in a cigarette smoking is obviously a highly oxidative challenge to the airway, so oxidizing perhaps more in the case of smokers. You would see more signaling down the RAGE pathway and less down the ST2 pathway, and that may have some effect on the differential response, so less of an alarmin type response and more of a remodeling type response, and that needs to be picked out as well. But also there's recent data from collaboration between Phil Hansborough's group and Dutch collaborators, which looked at the nature of IL-33 secretion in the lungs of smokers and ex-smokers. And the primary source in the epithelium is the basal epithelial cell. As Dave has highlighted, it's key. And that stable epithelial biology is important where this cytokine is sequestered and then released. And in active smokers, due to metabolic drivers, there's less of a population of the stable basal epithelial cells. So actually the biology of IL-33 signaling may be quite different in active smokers versus ex-smokers. I suppose the complexity is how we interpret those hypotheses in terms of biology in the context of the trials, and more importantly in the selection of patients that are going to respond. So I do feel that applying these drugs to a heterogeneous population and then purposefully doing subgroup analysis, looking at clinical labels of these different biologies are important. So in chronic bronchitic patients, in Th2 and non-Th2 inflammation, and the overlay of smoking becomes important. Clearly having a drug that works in all those patients would be ideal, but we have to understand where the signal lies, and I think the jury's still out in terms of where that may sit.
Thanks, Tom. And probably it's an important area that we've ignored in COPD, the potential differential response between active and former smokers. And when you look in some of the inhaled steroid studies, it's not there consistently, but it is there in a couple of large analyses. And it's going to be really, in my view, it's going to be really informative across the 3 programs that it's been identified a priori as a potential modifier, and we'll learn from the results. So another interesting question. So, and this question may be not just targeted at COPD, but in general. So, Jonathan, if you want to make a comment as well, just in general, how do we feel about the potential for differences in targeting the pathway if we have a ligand against the cytokine versus the receptor?
I think this is such a hard question for me to answer with the limited evidence that we have from infection in general. But I think ultimately some of the trials I'll talk about later, one looking at astegolimab, another tozorakimab, without spoiling some of that, no difference in those outcomes for the same infection, essentially. So at this point, I'd have to say I wouldn't expect there to be a different clinical outcome.
Yeah. Tom, anything extra?
Well, I suppose we have these dual signaling pathways, and so if you're blocking the cytokine, that may affect both. If you're blocking only the ST2 receptor, then you may not affect the non-ST2 signaling story. You don't really know the balance of those in individual patients. I think predicting your likely effects is going to be really difficult.
Sure. Thanks both. So we'll move on. And so just briefly, I'm going to touch on asthma, and then we'll move on. So some background information again on asthma, with its huge prevalence in the US, almost 25 million. We have 10 million annual asthma attacks, which results in almost 1 million visits to the emergency room, and this huge cost. 65% of individuals have been prescribed all corticosteroids amongst patients with persistent asthma. So the 3 drugs that I've been highlighting, they have all had phase 2 studies in asthma, and the ongoing clinical development is for tozorakimab. For itepekimab and astegolimab at present, there isn't any ongoing development. So I'll show you the phase 2A study for tozorakimab. So this, interestingly, was done in a selected asthma population, so early onset, so individuals who during childhood had the onset of asthma, and as you know, the majority of those individuals will then have allergic asthma. And it's an interesting attempt to homogenize the population. The patients all had moderate to severe uncontrolled asthma. In terms of blood eosinophil counts, then 3/4 had eosinophil counts less than 300. And I think one of the reasons for that relatively modest number who were not eosinophil high is the fact that the inclusion criteria rules out the adult onset asthma, which is frequently associated with a very eosinophil dominant disease. But these are all allergic asthma patients from childhood, and we don't have that phenotype in here. So the primary endpoint then is the change in FEV1 to week 16. There were lots of exploratory endpoints. There's some dose ranging here. So for the primary endpoint then, there was no signal, and this has currently only been presented in abstract form, but there were some interesting signals in the patients whose blood eosinophils were less than 300, that there was an increase in the benefit on lung function. And although not shown in my slide deck today, for astegolimab, when you look at that phase 2 data, there was a relatively flat effect on FEV1 in terms of a positive benefit across the range of eosinophil counts. And putting these data together, and very compatible with the COPD data, suggesting a class of medicine that can address non-type 2 inflammation. So, I'm going to hand over now to Jonathan to move us on to the next stage.
All right, thanks. So I know a lot of folks in here don't take care of patients directly per the statistic we had at the beginning, but I don't need to tell you that we really do need effective therapies for viral infections. So when we have over 1.5 million adults hospitalized with community-acquired pneumonia annually, a significant amount are due to community-acquired respiratory viruses. 14% of patients hospitalized with viral lung infections end up in the ICU. And early on in the pandemic, the median ICU stay for COVID-19 infections was 5 days. Now that's probably gone down across most patient populations. However, in immunocompromised patients and older patients who still develop severe COVID-19, that's associated with significant cost to patients and cost to healthcare systems. The mortality rate of patients hospitalized with viral lung infection is 3 to 12%. And the cumulative number of deaths from COVID-19 is over 1.2 million. So we know that viral lung infections impose significant burdens on patients and healthcare systems. Now, thankfully, the mortality, cumulative death slope there has significantly flattened out in the recent years and months. But there is still an overall rate of COVID-19 associated hospitalizations per the US CDC data, 67.6 per 100,000 people. And over that same time period, 2024-25 respiratory viral season, you can see the overall rate of RSV associated hospitalizations was 50.2 per 100,000 people. And I don't need to go into detail, thanks to my excellent colleagues here presenting the activity of tozorakimab and astegolimab, but this is the small summary of the existing data and trials that are ongoing in these viral infections. So we have a Accord 2 study, which was actually led by Tom here, and that was a phase 2A study targeting patients with COVID-19. And then an ongoing phase 3 study called the Tilia study, and that is enrolling patients with all types of respiratory viruses. And then for astegolimab, we have the COVASTIL study that was phase 2, also targeting patients with COVID-19. So to summarize the Accord 2 trial, you wanted patients who were sick but not too sick, 3 to 5 on this 9-point ordinal scale, this WHO severity scale. So patients requiring supplemental oxygen but not on invasive mechanical support. And these patients were randomized to receive either tozorakimab plus standard of care or standard of care alone, with the primary endpoint of time to sustained clinical improvement at day 29 and secondary endpoints of death or respiratory failure, survival duration of ICU stay, and hospitalization, and of course safety. Anytime we're looking at a COVID study, it's extremely important to understand the recruitment periods. As you know, things have changed drastically as far as treatments and how we manage patients, and even variants. So early on, 16 patients included from period 1, and this was declining hospital activity at the tail end of wave 1. There was significant but not universal use of dexamethasone at that point, and there was not much remdesivir use. In period 2, where a majority of patients were enrolled, there was a high level of UK hospital activity and near universal use of dexamethasone and really broad use of remdesivir. So there was no significant impact on the primary endpoint, which was sustained clinical response at day 29 when tozorakimab plus standard of care was compared to standard of care alone. There was, however, a numerical reduction in deaths, respiratory failure, and ICU admissions. Those were not statistically significant. And tozorakimab was generally well tolerated. You can see the pretty similar treatment emergent adverse events in both groups. So these results, I think, suggest that tozorakimab could be a novel therapy for patients hospitalized with COVID-19, and I think we need some more investigation. But with COVID, it's been sort of a moving target with who is the right patient, at what time would these treatments be beneficial? Is it before they're very sick or when they're really sick? I think it's hard to know based on the time periods that this was studied, how we can apply this to today's landscape, except to learn from this and apply it to other situations. And I think what a lot of us are really excited about here is an ongoing phase 3 study in hospitalized patients with hypoxemia that need supplemental oxygen. This is the TILIA study. Patients are enrolled in less than 36 hours to receive either a single IV dose of tozorakimab or placebo, and the primary endpoint being proportion of patients who died or progressed to invasive mechanical ventilation or ECMO by day 28. Key secondary endpoints: deaths, ICU admissions, days alive, and ventilator free. And I think what's great about this is one, targeting 446 locations across the globe, so we'll really get an international view of these patients. And also leaving the enrollment criteria broad to really understand which respiratory viruses IL-33 blockade might actually be helpful, and really trying to tease that out if we get such a large number of patients from all of these sites. And then finally, astegolimab, used in the COVID-STIL studies, was a phase 2 study in severe COVID-19 pneumonia. And patients here were randomized 2-2 to 1-1 to receive astegolimab or matching placebo with standard of care, or efmaridosokin alpha, which is an IL-22 agonist that's involved in tissue repair, also compared to matching placebo. And so that was at baseline, but if patients stayed hospitalized or still required supplemental oxygen at day 15, they were given another dose. And the primary endpoint here, time to recovery, and then key secondary endpoints looking at deaths, ICU admissions, and days alive and ventilator free. And I think as we've seen COVID evolve, some of these endpoints clearly need to change. And I don't have I don't think the golden outcome that we need to all focus on, but clearly SARS-CoV-2, given its evolution over the most recent months and years, deaths and ICU admissions might not be the right target for outcomes. So treatment with astegolimab or efmaridosokin alpha did not improve time to recovery in patients with severe COVID pneumonia. And so back to our faculty discussion here, which patients or subgroups could potentially benefit from emerging IL-33 targeted therapies. So again, trying to find that right patient at the right time, what specific subgroups, and for me, selfishly, being a transplant infectious disease physician, I am really interested in the immunocompromised populations that might benefit from this. I think not all immunocompromised populations are created equal, so that's not a really fair term, given the different quantitative and qualitative deficits that different patients have. But I think that might be a group that I would like to see any opportunity to prevent severe disease from respiratory viruses. And I think on the flip side, we have to be careful, are we harming patients more? Are there further immunosuppressive effects from IL-33 targeted therapies that might disproportionately impact patients who already have quantitative, qualitative deficits in both their innate and adaptive immune responses? Guys, any other subgroups that you think could potentially benefit?
Yeah, sure. I'll make a comment first. So it's interesting to hear you talk about this, because in your field, you're quite rightly very much focused on the acute response to a pathogen, and that makes me think about the role of IL-33 in the chronic diseases we've been talking about here, and a dual role that it's going to have in terms of, one, provoking persistent chronic airway inflammation and remodeling, and then on top of that, those patients will suffer with the events that you will see, and they'll range from moderate to severe. So I think these alarmins then will play a different role in disease therapy in different situations. And for For IL-33, then, I made a few comments about the type 2 response. All of the agents shown, they drop the blood eosinophil count by about 30%. And so the immediate reaction might be that this is then a type 2, anti-type 2 therapy. But the clinical trial data on exacerbations doesn't really support that. It supports a broad mechanism of action across immunity. So I think that picking a subgroup for this class of medicine probably won't be based on the simple linear scale we use in obstructive lung disease of low eosinophils to high eosinophils. There's probably more sophistication required. Tom?
Yeah, I completely agree. I mean, I think our biomarkers of biologic response in COPD are particularly blunt, and we've got one blood measure which we're using at the moment. In the next 10 years, there'll be a whole array of biological therapies out there, and picking the right one for a particular patient is going to be increasingly complicated and difficult to do unless we improve our predictive markers. So I think that's a real area of research that's required. I think the other thing is that when we're thinking about the individual patient, particularly in the context of acute viral infection, it's not just the patient, but it's the timing of that event. So an intervention at a certain point in the trajectory of their acute illness may be very powerful and useful, and at a different point may not be valuable, dependent on where they are. So again, understanding where a patient is in their cycle of inflammation and antiviral immunity is really important. And again, Jonathan, you'd probably agree that our tools to understand that are pretty poor at the moment.
All right. And next, given the concept of targeting IL-33 pathways, what other airway diseases or infections would you want to see explored? For me, I'm very, again, interested in the results of Tilia having multiple community-acquired respiratory viruses. I still, though there are some in vitro studies, mouse models looking at bacterial infections, I would like to see more evidence there. And then as we've already discussed in detail, what are we doing with this immunothromboses phenomenon, and what impact will IL-33 play there? I think all of those things related to infection are fascinating to me, and I think what I would like to see explored.
Yeah, we've discussed tonight, I think the areas we haven't gone into in great detail are bacterial infection, and that's because most of the data is preclinical. We haven't studied that in patients. You've highlighted the potential on cardiovascular disease, and that again might be context specific to when the risk of cardiovascular disease is heightened because in certain situations. Tom?
Yeah, and I suppose there may be other indications in airways disease. So perhaps the archetypal inflamed airway would occur in the bronchiectatic patient, and we've got almost no data understanding the potential of these therapeutic strategies there, both in terms of the acute exacerbation event, but also in terms of the dramatic remodeling we see in the response to dysbiosis and chronic infection. So again, a lot of evidence and discovery work is required perhaps in that indication.
All right, so to conclude, we have talked a lot about the pleiotropic effects on multiple immune inflammatory pathways that are involved with inflammation and airway remodeling and IL-33. And I think we've demonstrated here IL-33 is a key driver of underlying inflammatory mechanisms that are responsible for the progression of chronic lower respiratory diseases, but also with viral lung infections as well. Investigations of IL-33 targeting biologic agents are ongoing, as we have shown, and there's, I think, real promise of potential treatment strategies across chronic airway diseases and viral infections. So future directions include refining patient selection, as we've been discussing, and comparing anti-IL-33 ligand versus anti-ST2 strategies. I think that might have been the question that maybe stumped us the most with what remains to be explored. All right, post-test question 1. How confident are you now, after this great talk, in your understanding of IL-33 signaling and its pathophysiologic roles in lower respiratory tract disease and infection? All right, we're across the board. Moderately confident seems to be where we've landed. Oh, there we go. Before and after. It looks like we can get. Oh, it increased. Yeah.
Shift to the right.
The shift to the right. That's a win. That's a win. All right. Next question. All right. Post-test question 2. The ST2 independent IL-33 pathway has been shown to 1, impair epithelial wound repair and induce remodeling. 2, promote epithelial regeneration and reduce inflammation. 3, suppress type 2 immune responses in airway tissue. And 4, inhibit fibroblast activation and extracellular matrix deposition. All right, and we have a success here. All right, a winner. And there we go. And there you see before and after. All right, great. On to the next question. In their phase 2 placebo-controlled studies in COPD, the IL-33 targeting agents, itepekimab and tozorakimab, were both commonly found to blank. 1, significantly reduce rates of exacerbation in current smokers. 2, numerically improve outcomes in former smokers. 3, significantly increase incidence of exacerbation. And 4, numerically improve lung function in patients with blood eosinophils less than 100. All right, overwhelmingly number 2 is the correct answer. And there we go, before and after. All right. Post-test question 4, how familiar are you now with emerging biologics that target IL-33 inflammatory pathways in lower respiratory disease and infection? 1, not familiar. 2, somewhat familiar. 3, moderately familiar. 4, very familiar. 5, extremely familiar. We have 8 minutes, right? Okay. All right. Moved on to somewhat moderately. All right. There we go. Going that way. All right. Number 5, should there be an opportunity in the future to utilize biologic agents that target the IL-33 pathway, how likely would you be to adopt these newer therapeutic options? 1, not likely. 2, somewhat likely. 3, moderately likely. 4, very likely. 5, extremely likely.
Good question.
All right. Moderately, very, okay. All right, and for those of you still with us here, we have a little bit of time for question and answer session. We've received a few questions here.
So I'll read these answers. Thanks for all these. There's a whole array. I hope we can get through most of them. So this one is on asthma COPD overlap. Can you comment on the role of IL-33 signaling in asthma COPD overlap syndrome and whether baseline airway hyperactivity could explain efficacy of these therapies in different phenotypes? So perhaps, Dave, you might want to take that.
It'll be a short answer because we shouldn't be using the word asthma COPD overlap syndrome. So somebody's either got asthma and COPD or they have one of the diseases. So in people who've got asthma and COPD, then I think the clinical trial effects that we see in either of those diseases across the board should be, of type 1 and type 2, should be seen. I think the question's also related to bronchial hyperactivity. And so that's more related to asthma. And so if you improve inflammation, then you should get an improvement in bronchial hyperactivity, the magnitude of which will vary between different types of agents. So that's worth studying.
Okay, thanks. Another question, is there a known role of med versus reduce, excuse me, I can't read that, sorry. Reduce versus oxidized IL-33 in viral infections. Short answer, I think from what we've shown today, that we don't know yet. But this is another opportunity to really understand some more.
So something on steroids here. So do systemic steroids affect or suppress IL-33 production. So, Dave, do you want to comment on that?
Yeah, that's not been studied. So you would think that inhaled steroids probably wouldn't have much effect, but I think whether that's true, and I say that from a basic biology point of view, whether that's true actually in patient cohorts is a good question that needs looking at.
Yeah, agreed. Another few questions. So, would inhibiting TSLP and IL-33 be better than blocking one or other as monotherapy?
So I love the concept, and we didn't really have much time to go through TSLP, but there are some overlapping pathways. So theoretically, for example, ILC2 cells, they're upregulated by both of these alarmins, and if you block IL-33, there's still capacity for TSLP to drive ILC2 cells to produce those type 2 cytokines. So I think that's a great concept, that it would be fantastic if there were one or two companies who took up the challenge and we could answer it.
Yeah, I mean, I think this whole area of multiple targets in single therapeutics is an emerging space. I think even at this meeting there's been quite a lot of presentations on that evolving therapeutic strategy. So I think it's going to get even more complicated in understanding the phenotypes of responders in multiple cases. But I suppose if you're broadening your target array, you may get a broader response phenotype. So that would be exciting to think about. And then an interesting question, could remission of disease be a possibility from targeting IL-33?
Yeah, so I think we have to be, in both asthma and COPD, just personal viewpoint, I think we have to be careful what we actually mean by this terminology. So I would start with disease activity. So for both the diseases, what we're talking about here is an active process. That's what disease activity is, an active biological process that you can reverse or suppress. That process is linked to the pathology, and then if you reverse or process it, you will have better clinical outcomes. So I think that's what we're talking about here. And once we understand how the reduction in IL-33 activity leads to better clinical outcomes, then we can address a question like, can it induce remission? A point about both diseases are, though, to achieve remission, we need to intervene much earlier. If you have chronic end organ damage, then really, whether we call it remission or not, if the patient has a degree of disability, it's a meaningless phrase.
Agree. I think one of the challenges in COPD will be not intervening early enough, but intervening early enough and finding endpoints that are modifiable in the context of that disease trajectory. So that we need to do something in COPD which is not just about exacerbation frequency to track that, but that's interesting. Jonathan?
A lot of the same questions here, I mean, about oxidized versus reduced, and I think everyone in the audience is on a similar track mind here.
Thinking about the biology. And the last one really asks about other indications, so bronchiectasis we've mentioned, but also cystic fibrosis. I'm not aware of the data in CF. I don't know if you guys have seen CF data. So I think there are areas of discovery required in the context of chronic lung disease. And watch this space. We've got some very good assays for both IL-33 and ST2 in different biofluids at the moment. And I'm sure there's people at this conference who will be asking and answering those questions soon. That's the last one. Yeah.
All right. So I guess with that, we'll close. Thank you, and please remember to submit your evaluation form. We appreciate the attention and the questions. Thanks so much for coming.
Thank you.